All right, welcome back everybody. So in this next video, we are going to talk about post-renal acute kidney injury. Recall from our previous videos that we talked about how a pre-renal kidney injury occurs before the kidney, an intrarenal injury occurs within the kidney, and a post-renal injury occurs after the kidney. Remember, just the general definition of an AKI is a deterioration of the kidney function overall. So we're losing our ability to actually filter and reabsorb the substances in the normal manner that we would. There are a variety of different things that can cause damage to the kidney, and in a post-renal acute kidney injury, we're primarily going to be talking about things that cause outflow obstruction. Notice the key word here being bilateral. The reason that's important is because typically if only one side of the kidney is actually obstructed, the other side can function and we can preserve a pretty normal GFR and maintain kidney function with only one kidney. Now, this is not always the case. There are a variety of different things that can cause a patient to present with AKIs, but for test-taking purposes, just kind of a general statement, we typically think about things that cause a bilateral problem with the kidneys as things that can cause post-renal acute kidney injury. So what happens if we have an obstruction after the kidney? Well, let's take one of the classic examples, which is BPH. So in BPH, we have a typically normal prostate, right, that has then developed into an enlarged prostate. It stands for benign prostatic hyperplasia. So what happens if our prostate has significantly increased in size? Well, it's going to cause an obstruction with urine actually leaving the body. And what happens is that we get a buildup of backwards pressure. So typically know that blood enters through the afferent arteriole, and some of it is actually filtered, making up our GFR into the tubules. But what happens is if we have a downstream obstruction with an enlarged prostate, shown here, that pressure is actually going to be pushed back into the bladder, back up through the ureters, and ultimately in through the tubules as well. And we refer to this as an increased retrograde hydrostatic pressure. So normally our GFR, right, is trying to come this way as stuff is filtered at the glomerulus, but now we have a counteracting pressure that's going the opposite direction. And what's this effect going to be on GFR overall? Well, it's going to decrease our GFR overall. So that is to say, this backload of urine increases our tubular pressure, decreasing our GFR, which we're seeing down here. Now, that is why these things occur. Let's talk about what are some reasons why this might actually occur. We already talked about kind of the classic one here with our etiology of BPH. So anything that enlarges the prostate enlargement, classically from BPH or even prostate cancer, is going to cause an obstruction, right? And we can appreciate how this is creating a bilateral obstruction. Because the prostate is distal to both the bladder and the ureters, this is why it could cause a bilateral obstruction and not both kidneys are affected. If something was occurring more proximally, such as in the kidney, we can see how this might only affect one kidney in general. Some other classic causes that they like you to know include nephrolithiasis. Now this one's a little bit tricky, right? Because we don't classically think about patients having kidney stones on both sides. However, we must appreciate that if it were to occur, right, from a medication or various types of pathologies, right, which put patients at a higher risk of developing kidney stones. A classic one we talked about in this nephrology section are patients with a type 1 RTA. Remember, these patients have trouble excreting hydrogen protons into the tubules. And if they can't secrete protons into the tubules, they get a very alkaline tubular environment with a pH typically greater than 5.5. This predisposes them to have a higher risk of kidney stone formation. So potentially in these types of patients, they could develop kidney stones on both sides. We also want to consider some other things such as congenital anomalies. The classic one being posterior urethral valves. And recall that in posterior urethral valves, patients have a membranous fold at the urogenital membrane, which can create an obstruction. So if the bladder typically would fill up with urine and then leave the body and be excreted, well, now we have this obstruction right here, this posterior urethral valve, which is causing an obstruction and not allowing the urine to leave as easy as it normally would. This condition is very similar to BPH here because what's this going to do to the patient? Well, a distal obstruction to both kidneys, right, in the bladder, in the urethra, is going to cause a backup of urine bilaterally. And finally, the last one that they like you to know is neurogenic bladder. The two most commonly tested ones are going to include a spinal cord injury or an SCI or MS, multiple sclerosis. And these are neurological things that can happen to a patient which can decrease their ability to actually contract the bladder. This decreased ability to contract the bladder decreases our ability to actually push urine forward. And so again, we're going to get a similar thing here. If we're not pushing urine forward, we are actually getting a backup of fluid into the kidneys bilaterally. This is again going to lead to our primary problem with this condition, which is a decrease in the GFR. Now, when we talk about the diagnostics, we want to focus on the similar labs that we've been using to distinguish our other types of AKI. We talked about findings we would see in a pre-renal acute kidney injury, an intrarenal acute kidney injury, and now we're going to talk about the post-renal acute kidney injury. Now, it's very tricky because if you look here, you see a variety of our typical conditions such as urine osmolality, urine sodium, fractional excretion of sodium, and serum BUN to creatinine ratio have been listed as varies. And that is to say, there's not really a classic presentation in post-renal AKI. The amount can actually vary. The labs can actually vary. And so we have to rely a little bit more heavily on our clinical clues. What's the patient's history? What does their imaging show? To really differentiate this type from the other types of AKI. Now, the reason for these varying labs is that it can actually change over time. So recall, typically we're filtering stuff from a high pressure system to a low pressure system, right? The filtration, the GFR that we're forming goes from the Bowman's capsule into the proximal convoluted tubule. But recall, if we have an obstruction distally, right, we're going to get a backup of pressure. We talked about how that backup of pressure can actually be pushed back all the way to the glomerulus itself. And that's going to change things. Now we have a high pressure system in the glomerulus going to another high pressure system. And this is why we get a decrease in our GFR overall. Now what happens is a lot of substances that are filtered, right, our sodium, our water, our urea at the glomerulus can actually get pushed back into the body because it's dealing with another high pressured state. So instead of going forward through the nephron itself, through the tubules, it gets forced back into the body. So when we reabsorb high levels of sodium, water, and urea, our labs are going to look a particular way, right? We're not going to be excreting a lot of sodium. So early on, this high pressure system is actually going to cause our labs to become pretty consistent with what we would expect to see in a pre-renal AKI. We're reabsorbing sodium, or it's being pushed through the high hydrostatic pressure occurring right here. So we're going to get a FeNA or an FeNA of less than 1%. That is the amount of sodium that's excreted from the body over the amount that is actually filtered. So that's fairly low. We would see a BUN of creatinine ratio of greater than 15:1. Again, because the high hydrostatic pressure is pushing the urea through. So we're bringing back more of it into the body. Thus, we have a lot more BUN or a lot more urea relative to creatinine. We would also expect to see the urine sodium be less than 20 and the urine osmoles to be greater than 500. Why? Because we're bringing back more water, and that's creating more of a concentrated system in the tubule itself. Now, as this progresses, the cells, which I'll draw as these boxes, actually can get damaged, they can necrose, and they can die off. What happens now is a little bit more of a picture that's consistent with an intrarenal acute kidney injury. So as these cells get damaged and slough off into the system, right, we lose our ability to bring back molecules, and some of our transporters are damaged. So I said, as cells are damaged, the lab values can actually change. Now, later on in the process, we might see a fractional excretion that's more consistent with greater than 2%. This is indicating we're not able to reabsorb as much sodium as we would like to. We would also see changes in the BUN to creatinine ratio. They would become less than 15:1. Why? Because we're not bringing back the urea in the same amount that we typically would. This impaired ability to transport urea across the system is going to decrease our ratio of BUN relative to creatinine in the body. We would also see the urine sodium become greater than 40. And again, this is more consistent with an intrarenal acute kidney injury. And finally, we would see the urine osmolarity be less than 350. The reason is when we damage these transporters that bring back sodium, bring back urea, we're also losing the ability to bring back water. This leads to a more dilute urinary sample. And so this is why when you see these labs as varies, right, it doesn't seem super helpful, but the reason is because it depends where in the process you are for a post-renal AKI. The labs will change and they will vary over time. This makes it a little bit less useful for test-taking purposes. Now, the two key things I really need you to know to get your questions right on test day is the key feature, which is anuria. Recall, we said anuria means that patients are not producing urine, or they are without urine production. And the key imaging I want you to know is that of the ultrasound. And the reason is because these will give you the clues that you need to diagnose a patient with a post-renal acute kidney injury. The labs are not as helpful here. So if a patient has an obstruction, right, and they're not able to produce urine, that makes sense that we might see, potentially oliguria, which is low urine output, or anuria, which is essentially no urine output. But also the ultrasound. What would we expect to see if a patient has an obstruction, let's say at the prostate, and you get a backup of fluid into the kidneys? What might you see on ultrasound? That's right, you might see bilateral hydronephrosis. So whereas in a normal patient, right, you might expect to see the kidneys with the ureters attaching to the bladder, in somebody that has bilateral hydronephrosis, these kidneys are going to get markedly larger, and this will be particularly noticeable in the ureters themselves, where they will expand and become very wide, which you can see on ultrasound. Now, while an ultrasound is the initial best test to do because it's fast, it's cheap, it's also worth noting that an actual CT can be done as well, specifically a non-contrast CT, if we are really evaluating for urinary stones or nephrolithiasis. And finally, the last thing I want to talk about in this video involves our management options. So remember, with AKI, we always want to think about treating the underlying cause. We want to provide symptom management, so you want to provide fluids, discontinue any medications that can be contributing, such as nephrotoxins. But with post-renal AKI, sometimes there's some additional things that they might ask you about, one of which is to move the bladder obstruction, right? If you have significant obstruction, you might need to use a urethral or suprapubic catheter for the patient. Urethral goes through the urethra, and a suprapubic catheter is inserted above the pubic bone. Additionally, if the obstruction is more proximal in the urinary system, you might have to relieve the obstruction at the pelvis itself. This can include a urethral stent or a percutaneous nephrostomy. These are procedures that you would consult urology to perform. So just to summarize here, the classic presentation that they ask students about is very commonly an elderly man who has signs of BPH, right? They're presenting with frequent urination, dribbling, low, weak stream to the urination, and they have an obstruction. You can get an ultrasound ordered, which would typically show you bilateral hydronephrosis if the condition has been going on for a while, and this is really an important step in working up these patients. They can potentially give you the labs, but recognize the labs are less helpful in post-renal AKI because it can vary depending on the patient's overall state and condition. So what you're really asked to do is recognize, okay, here's a patient with some kind of kidney abnormality in addition to a prostate abnormality or in addition to something that is causing an obstruction in the urinary system, and make the connection that based on their exam, their history, and their imaging, that they most likely have an AKI due to a post-renal problem. So just a quick summary of this video. Post-renal AKI is typically due to a bilateral outflow obstruction. There are a variety of different things that can cause this. When we work up these patients and we look at their labs, we have to keep in mind that the labs do not always give a clear-cut answer as to what the patient's condition is. If we suspect an acute kidney injury because they have elevated creatinine ratios, we certainly want to work that up and get more lab studies, but keep in mind that the classic things that we need to know to diagnose this include a patient who has low or no urine output, and using our imaging studies to actually get an ultrasound of the patient's urinary system. And finally, the management options here are going to be our typical AKI management options, including supportive care. However, with patients who have an obstruction, there are a variety of different things that we can do to try and remove those obstruction and hopefully relieve their symptoms going forward.